Okay, so this section is endocrinology. A 50-year-old woman with a 10-year history of diabetes type 2 comes to the physician for a follow-up examination. Current medication include glyburide and metformin. She is 5'5" and 200 pounds. BMI is 200, so she's heavy. Physical examination shows decreased sensation to pain and temperature. Ankles, truncal obesity, and acanthosis nigricans on her posterior neck in both axilla. Which of the following is the mechanism of action of metformin? Okay, so almost the rest of the question is useless. Simply asking what is the mechanism of action metformin. Person has diabetes, advanced diabetes, she's obese, she has peripheral neuropathy. All of those are irrelevant for us because they're asking for one thing and one thing only: mechanism of action of metformin. Okay, let's do this. Metformin. Now, this is how I know metformin. It makes life much easier. It is a metabolism regulator of glucose. Metabolism. Okay, so metabolism formation. So it regulates glucose metabolism. Focus on that. That should always help you. Now, what is glucose metabolism? Of course, glucose metabolism involves glycogen synthesis, glycogenolysis, gluconeogenesis. Okay, and it can include a glycolysis. Okay, so simply glycogen synthesis is storing glucose in the form of glycogen. Glycogenolysis is breaking down glycogen back into glucose. Converting glucose into glycogen is glycogen synthesis. Glycogenolysis is breaking down glycogen back into glucose is glycogenolysis. Gluconeogenesis is making glucose from non-glucose particles or sources, such as making glucose from lipids, from proteins, and from lactic acid. Glycolysis is simply taking glucose and burning it to end result is to make ATP. Okay, so these are some, if maybe I forgot some others like glucose 6-phosphate shunt and other pathways, but these are some of the major pathways of glucose metabolism. We know that metformin is anti-hyperglycemic agent. So what is its function? Its main function is to decrease plasma glucose, right? Okay, glucose in plasma. I should have said plasma glucose, but glucose in plasma. That's the main function of metformin, right? As far as we know. So metformin, what does it do? It decreases plasma glucose level. Plasma glucose level. That's the function of it. So if you have that in mind, it will make life easier, so you can focus on that, sort of, to answer everything else. If we increase glycogen synthesis, plasma glucose will decrease. If we decrease glycogenolysis, because glycogenolysis, it's one purpose only, to increase plasma glucose, and then gluconeogenesis to increase plasma glucose, you want to inhibit that. And glycogenolysis, it promotes that to increase glucose usage, right? So that's what metformin will do. Metformin promotes glycogen synthesis. It inhibits, blocks, decrease glycogenolysis. It inhibits, blocks gluconeogenesis. It promotes glycolysis. Okay, so that's the main function of metformin. Now, in order to do that, you know what you have to increase in order to remove glucose from plasma. Where do you remove glucose from plasma? Obviously, you take up glucose into cells. So you want to increase glucose uptake. Glucose uptake by cells. Okay, so you want to increase glucose uptake by cells. And guess what? Metformin does that. To do that, that means you want to make sure that your cells are more responsive to insulin. So metformin also increases insulin sensitivity. So the cells will respond much better to insulin, so it can take up more glucose. So these are the mechanism of metformin. Okay. Now that we have done that, let's see what are any of these choices. Or maybe before we go to the choices, you should also know that the side effect, all drugs, you should know side effect and mechanism as far as step 1 is concerned. Side effect, the main one is lactic acidosis. Lactic acidosis, and maybe GI disturbance, like let's just keep it GI disturbance. These are the main side effects. Okay. It's also cleared by the kidney. Metformin is cleared by kidney. So in kidney diseases such as chronic kidney disease, you have to be careful with metformin. Okay. So you don't use it in chronic kidney disease. It's contraindicated. Okay. Now let's go back to see what are these mechanisms. So A tells you decrease intestinal carbohydrate digestion. So A. Well, a drug that does that is known as acarbose. Acarbose. Acarbose is a medication that inhibits or blocks alpha glucosidase. Alpha glucosidase. Alpha glucosidase is a brush border enzyme that promotes glucose absorption. Okay, so inhibits alpha glucosidase. If you inhibit alpha glucosidase, obviously glucose absorption decrease intestinal. So let's just say this, intestinal glucose absorption. When I use the term absorption, you should know it's only in the intestine. Reabsorption is in the kidney. So I don't even have to say intestine, but for your sake, I'm saying that decrease intestinal glucose absorption. Okay, so that's what acarbose does. Acarbose inhibits alpha glucosidase. If you don't have alpha glucosidase, that means you cannot break down glucose and glucose cannot be absorbed. Okay, so by decreasing glucose absorption, plasma glucose will remain low. So obviously, if that is the case, this cannot be the answer. Okay, so A would not be the answer because we're looking for something, the action of metformin. Okay, metformin, I would give you all the options. Next one is increased beta cell insulin secretion. I didn't see that none of these mechanisms that I mentioned here for metformin are B. B, increased beta cell insulin secretion is the function of many drugs, such as liraglutide. Liraglutide. Liraglutide is a drug. It comes from the class of glucagon-like peptide 1. Okay, so inhibits glucagon. It promotes. It's glucagon-like peptide agonist. Okay, so what is this? What does GLP-1 do? It increases insulin secretion. Okay, so it increases insulin secretion. Okay, so that would be liraglutide. Well, there's other medication as well. Linagliptin. Gliptins also increase insulin secretion from beta cells of the pancreas, but linagliptin or gliptins are DPP antagonist. Sulfonylureas, like in our question, we have glyburide. Glyburide is also increased insulin secretion. Glyburide right here. Glyburide also increases insulin secretion. Okay. Increases fat deposition in cell. That's insulin. Metformin doesn't do that, so that would be insulin. Okay, insulin promotes lipid triglyceride synthesis and then deposition in the adipose tissue. Increase hepatic triglyceride synthesis, that's also insulin. Okay, the last one inhibits hepatic glycogen synthesis. Yeah, that's the mechanism of action that we want. That's the mechanism of action of, that's the choice, that's the answer for metformin. Right here we said the gluconeogenesis, right? Gluconeogenesis, yeah. Okay, so hopefully this should be straightforward for you, but I mentioned the other medication because these medications are all very high yield. Make sure you know the mechanism of metformin, make sure you know its side effect, make sure you know its metabolism in terms of cleared by the kidney. Medication that increases fat synthesis and fat deposition is insulin. Medication that increases beta cell insulin secretion is liraglutide or gliptins, linagliptins, and so forth, and glyburide, right? And medication that decreases absorption of glucose from intestine is acarbose. Okay, so hopefully this helps. Let's go to the next question. Okay, so this question is 25-year-old man is brought to the emergency department because of headache, nausea, vomiting, confusion, weakness. On arrival, he becomes delirious and develops seizures. So for all symptoms, neurological symptoms, the patient reports that he started a new weight loss program, which includes long run and drinking lots of water. Okay, so this morning he weighed himself to be 60 kilograms, 132 pounds, but he now weighs about 138 pounds, which is gain of what, six pounds just in a day or half a day. His pulse is 120, respiration 18, blood pressure is 90/60. On physical examination, his skin is dry, cool, and to touch. Okay. Then they give you the lab values. Sodium is 116. Sodium 116 is very low. Normal sodium should be 142. Potassium is normal. Okay. Chloride is slightly low, should be 95 to 105. Bicarbonate 22 is normal. Urea nitrogen is normal. Glucose is normal. Creatine is normal. I know these values, but you guys will get a lab sheet on your exam. But if you do a lot of questions, you sort of remember the main ones. It kind of helps you to speed up answering questions. The patient condition is most likely due to which of the following. Okay, so first, let's actually diagnose this patient, right? So what is this patient having? If we don't diagnose it, how do we know what is the cause of this patient's condition? If you look at it, so the sodium is low. Sodium is 116. Very, very low. Okay. Other electrolytes are normal. So that's one thing. Second thing, so that's obviously hyponatremia. Okay, so let's say our diagnosis is what? Hyponatremia. Okay, so this is hyponatremia. If this is hyponatremia, but there are symptoms, right? So it's symptomatic hyponatremia. Symptomatic hyponatremia. And what are the symptoms? Why am I doing it this way? Let's do it this way. So our diagnosis, it looks like it's hyponatremia. It's hyponatremia. How do we know that? Sodium concentration is less than 140. So in this case, it is 116. That's very low. Okay. And then we have symptoms of hyponatremia: headache. Okay, so we have headache, we have nausea and vomiting, we have confusion, and then we have weakness, seizures. Okay, so these are the symptoms. Plus there was one more thing. It was weight gain in a day, acute weight gain, right? Weight gain, which was within a day. Okay, so very rapid weight gain. And he was drinking a lot of water. Drinking lots of water. Because that's the program he's attending to lose weight. Okay, so the cause of hyponatremia are several causes. But at least now we know that this person is having hyponatremia. Now, why do you think in hyponatremia you will have these symptoms? Imagine there is your blood vessel, and here are neurons or nerve cells. Let's say neurons. Okay, as the concentration of electrolytes or solute decreases, this solute becomes, in case of in case of low sodium, because sodium is the most important extracellular molecule or solute to maintain plasma osmolarity, right? Okay, if that is the case, if that's the case, you guys, sodium that is low, so this, the solution in blood vessel, let's say this is blood vessel, solution in blood vessel is hypotonic, right? Hypotonic. And the solution in the neuron is eutonic, right? It's the same as, it hasn't changed, eutonic. Or isotonic. I mean, why am I using the term eutonic, which is the same term, meaning the same thing, but let's just use the appropriate isotonic. Now you know that fluid or water will always go from high water to low water. Hypotonic solution has more water. Okay, it has more water and it has less solute. Whereas isotonic, the solute is greater. Solute is at least more than hypotonic. It's more than hypotonic. And water is less than hypotonic. Okay, so if that is the case, you can think of it this in two ways. Water will always travel from high water to low water. And that's the case for everything, gases, solute, water, whatever. Things tend to go from high concentration to low concentration, right? Because water is a universal solvent, we use those terminology for it. But anyhow, so the quantity of water in blood vessels is much higher than in neurons. So on osmosis is the diffusion of water from high water to low water. So water will always travel into cells. So that's, you can look at it that way. But you can also look at it as if there is more salt in neurons, less salt in blood vessel. So water will always travel from hypotonic solution to hyper or isotonic solution. Okay, so this will cause the neurons to swell. When the neuron swells, the end result is cerebral edema. Cerebral edema, which can be very dangerous, can be lethal. So as a result, the signs in cerebral edema would be, as the neuron swells, well, the patient is going to experience headache, okay, because increased pressure now. And it's going to compress the nausea vomiting center in the medulla, okay, in the fourth ventricle, so nausea and vomiting. It will cause neuron functionality to be affected, so cause confusion, weakness, and eventually seizures. So these symptoms make sense. But usually the three symptoms that I always look at when I expect hyponatremia are the following three symptoms: headache, lethargy, okay, and confusion. So this is the triad. This is the triad. When you see it, in addition to, this will make suspicious, right? But then in addition to that, if you have sodium, plasma sodium 116, this is 100% hyponatremia. Done. So we know this is hyponatremia. The question is telling it is hyponatremia. Now they're asking, what's the cause? Okay, this hyponatremia is caused by what? So let's go to the cause of hyponatremia. So let's go to some causes of hyponatremia. Let me erase this. I'm going to make this bigger so it's quick. Yeah. Okay, so the cause of hyponatremia. Well, hyponatremia could be euvolemic hyponatremia, hypovolemic, and hypervolemic, right? In this case, we know that the volume is increased, so it's hypervolemic. You see weight gain, drinking lots of water, this person, so this is hypervolemic hypernatremia. Meaning plasma volume is increased, but still, typically when we have hypernatremia, we expect plasma volume to be low, but it's okay. So in hypervolemic hypernatremia, what could be the cause of this hypernatremia? And that's what we're looking for. Okay, Okay, so what are some causes of that? Well, you know that in cirrhosis, because of albumin deficiency, we have much more fluid, so that's one cause. Nephrotic syndrome is protein loss in the kidneys. Cirrhosis, you cannot make proteins. Protein synthesis is the function of liver, so no protein deficiency. Nephrotic, you lose protein, right? So that's one cause. Two causes: congestive heart failure. Okay. And then of course we have too much fluid intake, right? So let's say excessive fluid intake can also cause that. So at the end of the day, it causes sodium dilution. So it's a dilutional hyponatremia. You can call it by that name too, dilutional hyponatremia. All right, now we have diagnosed it. Once we have diagnosed it, we're going to look for these causes, either cirrhosis, either nephrotic syndrome, either CHF, or this intake, right? So we're looking for those signs and symptoms. But let's see. ADH. So now we look at the choices. So A, ADH secretion, nope. Decrease aldosterone, nope. Excessive fluid intake, yeah. That was one of our options. So we're going to pick quickly C. This is our answer. So this is dilution hyponatremia, because this patient was working out so much, and then he drinks so much water that he gained about 4 pounds in one day because of fluid. That's simply like from 132 pounds to 138, 6 pounds he gained in one day. You cannot gain that by eating food, and that is because of excessive fluid intake. Okay, if that is the case, then we know our answer, but let's go over the choices. ADH. So choice A is ADH. Now remember that ADH acts on the collecting ducts in distal convoluted tubule of the nephron. The main function of ADH is to increase aquaporin expression on the luminal surface of nephron, and aquaporin only takes water, pure water. So if you have too much ADH, so let me write it down here. If you have too much ADH or increase ADH, so increase ADH will cause increase in plasma volume, but it will cause hyponatremia, decrease in sodium concentration, right? Not quantity. It causes dilution of sodium, so it will cause hyperosmolarity. But in this case, we have an A, we have decreased ADH. So if ADH is decreased, sodium concentration should increase. So if ADH decreases, sodium concentration should increase, and it should cause hypernatremia, not hypo. Our answer, our condition is hyponatremia, right? We have hyponatremia. Let me highlight it for you. Hyponatremia. But choice A is telling us hypernatremia, so we're not going to choose A. It's incorrect. Let's look at aldosterone. Aldosterone also acts on the collecting ducts. Aldosterone acts on the collecting ducts. Okay, so if this was a quickly, let me see quickly. Looks like it's talking about the nephron, so let's just do nephron. So let's say this is the nephron. On the nephron, we have these green cells and red cells. So these are intercalated cells and principal cells. So what aldosterone do? Aldosterone simply causes reabsorption of sodium into plasma and causes excretion of potassium into urine. So therefore, aldosterone, and I'm going to write down here, aldosterone, it's extremely important. You have to know aldosterone. It's on the exam 1,000%. So aldosterone will increase plasma sodium. It'll increase plasma sodium, and it will decrease plasma potassium. It will decrease plasma potassium, and it will cause alkalosis. Okay? So if that was the case, we would expect for aldosterone sodium to be, if aldosterone was, but this is the normal function of aldosterone, sorry. So B is saying decrease aldosterone. If aldosterone is decreased, we expect decrease in sodium, right? But we will expect increase in potassium, and we'll expect acidosis. Aldosterone deficiency, acidosis, okay. But we don't have that. We have, sure, sodium is low, but look, potassium should be high, but our potassium is normal. So therefore, B is not a good choice. Let's look at diuretic. Diuretic, let's say diuretic, let's say thiazide diuretic. Diuretic blocks sodium chloride channels. So if you block sodium chloride channels, you lose a lot of sodium and chloride, and you lose fluid. Okay, you will lose fluid as well. So with diuretic, you will expect low sodium because you lose sodium. You would expect low chloride. You will lose chloride, which should be proportional to sodium, but in this case, we have it slightly low. But you will also lose volume or fluid. In our questions, we have gain of fluid. So it's hypervolemia, but this diuretic will cause hypovolemia. So that cannot be an option. Okay. Increased sweating again is the same thing as diuretic. So you lose, but it's the same concentration. It doesn't affect concentration. Hopefully each choice makes sense to you. It doesn't matter how you get a question as long as you get it correct. I'm going over each choices so you guys can understand the other options. And these are USMLE questions. I can simply change something so the answer becomes A or B or C. So make sure you know all the options and you have a good knowledge of answering these questions. Okay, so the next question. A 40-year-old female with Graves' disease. Whenever you're given the name of a disease in a question, you should expect a question that's not about diagnosing, it's about something else. A 40-year-old female with Graves' disease comes to University Hospital because of heat intolerance, diarrhea, weight loss, insomnia. On physical examination, she has warm skin, fine silky hair, and exophthalmos. Plasma triiodine tyronine, which is T3, and T4 thyroxine levels are elevated. Which of the following best describes the action of these thyroid hormones in target tissue? Okay, so they tell you like this person has Graves' disease and then give you the symptoms of Graves' disease and the lab result of Graves' disease, which is just throwing you away. But it's not necessary because the question is asking what's the function of thyroid hormones on target tissue. That's it. That's what we have to answer. Okay, but let's just do this anyways because I am teaching, you're learning. So for the purpose of learning, let's do this. Graves' disease is hyperthyroidism. Okay, it is hyperthyroidism, no doubt about it. But the cause of Graves' disease is thyroid stimulating immunoglobulin or TSI. TSI is nothing more than an antibody or immunoglobulin that acts on the TSH receptor to activate TSH receptor and increase production of T3 and T4. Okay, so it acts just like TSH. TSI is the same as TSH, but it's an immunoglobulin or antibody. This is an autoimmune disease. Autoimmune diseases are always going to be common in female. So expect female in their 40s and 30s. Okay, and that should be general rule for you. 30s to 40s. Okay, so all autoimmune diseases are common in female because of the estrogen. So Graves' disease, sure. So if it's Graves' disease, it's going to be hyperthyroidism because we have an antibody that stimulates the thyroid gland. And it not just stimulates one area of the gland, it will be diffuse hyperplasia of the thyroid gland. So hyperthyroidism. I will expect hyperthyroidism, And the symptoms of hyperthyroidism should be so natural to you that you don't have to think about it, second guess yourself. You must understand and memorize on why you have these symptoms because thyroid hormone increases your basal metabolic rate. Thyroid hormone increases your basal metabolic rate. So therefore, if you increase your metabolism, just imagine you when you run, when you exercise, what happens? Your body is going to produce more heat. It's going to sweat. If you have some food in your intestine, intestinal motility will increase, cause diarrhea, you lose weight, and you're more alert, so you will have insomnia. So the symptoms that are in this case, like heat intolerance, diarrhea, weight loss, insomnia, and warm, moist skin, sweaty, warm skin, fine, silky hair, these are all signs of hyperthyroidism. But what makes it grave, so I'm going to say plus, because Graves' disease has additional signs and symptoms that are unique to it. It is hyperthyroidism plus ophthalmopathy. some pathology of the eye, for example, proptosis, diplopia. Okay, so that's one, and it causes peritibial edema or maxedema. Okay, so look for those. Those are extremely important. So you need to know that, right? So peritibial maxedema. Okay, so look for these signs. Plus, maybe look for palpitation, like what do we call it? AFib. So, anyways, this was just additional information. Doesn't help us in this case, but let's go. So we know it's grave disease. In grave disease, we have increased production of T3 and T4. Okay, so the question is asking you, what is the action of these T3 and T4? What did they do? How did they act? How did they produce these symptoms? Okay, let's do this. Now, thyroid hormone, so if this is the cell, this is the cell, let's do this. So this yellow is the cell. So cell, in order for hormone to act, we have different types of hormone. We have peptide hormones, we have amide hormones, and we have steroid hormones. And T3 is simply made from tyrosine. Thyroid hormones are made from tyrosine, which is an amino acid. So these are amino hormones or amide hormones. The issue with here, let's say here is the nucleus. Let me make it a little bit bigger. The nucleus of a cell. Let's change the color of the nucleus. Okay, so we have a nucleus. So T3 and T4. T3 and T4. Number one, they can go directly into the nucleus. On the surface of a cell, we have a transporter. It's called a thyroid hormone transporter by facilitated diffusion. So this transporter will transport the thyroid hormone into the cytoplasm. And then it will go through nuclear pores. They'll go into the nucleus. In the nucleus, or in the cytoplasm, you have a thyroid hormone receptor. Thyroid hormone receptor. So there you go. The thyroid hormone receptor has 3 domains on it. It has the DNA binding domain, in this case red, and it has green hormone binding domain. Okay, and then it has transcription factor binding domain. Which color should I use? Dark blue. Okay, so these are the 3 domains. Maybe I use gray then. Yeah. So this is the thyroid hormone receptor. It has these domains. Once the hormone comes in attached to it, let's say the hormone is dark. When the hormone comes in attached to its receptor right here, let's say this is the thyroid hormone. This dots, these are thyroid hormones. It comes and it binds to its receptor. Then the receptor becomes active. It becomes transcriptionally active. It causes the transcription of DNA. Transcription of DNA will then produce the products that are responsible for metabolism. Okay, so that's the whole idea. It is this receptor of thyroid hormone is intracellular receptors. Okay, intracellular receptor. So that's the mechanism. That's how it causes increase in metabolism. And then let's add to this. Let's say this is the DNA. So then it will cause DNA transcription into mRNA. And then mRNA will be converted to protein, which is translation, or the products, right? The products are made in the cytoplasm, not in the nucleus. So that's the mechanism of action of thyroid hormone. Let's go with A. Both T3 and T4 binds thyroid receptor on the cell surface. No, the receptor of thyroid hormone is not a cell surface receptor. Okay, those hormones, so the hormones that can bind to the cell surface, let's say in this case, let's call this red, let's say glucagon. Glucagon is a peptide hormone. Peptides are charged molecules. They cannot diffuse into the cell nucleus, and they don't have a transporter like T3 and T4. So all peptide hormones, the general rule is this: peptide hormones They bind cell surface receptors, such as G protein, tyrosine kinase receptor for insulin, for example. So, okay. So A is talking about what? It's talking about peptide hormones. Every hormone is peptide hormone except steroid and thyroid. Okay, so we'll, as long as you memorize which are steroid hormones, which are thyroid hormones. So steroid hormones are number one, estrogen, okay, testosterone, and then what else? Cortisol and aldosterone. So these are steroid hormones. And then we have amide hormones. In this case, it is T3 and T4. Okay, so as long as none of these six, they're all peptide hormones, just for our purpose. So A is talking about peptide hormones like glucagon, like insulin, okay, like epinephrine, norepinephrine. So they act on the cell surface and they will go to the cyclic AMP pathway, for example, in this case, and cause the cellular reaction. Both T3 and T4 enter the cell nucleus. That is correct. So the answer should be B. Okay, the answer should be B, as we discussed. T3 is converted to T4 in cytosol. No, T3 converted to T4 in the extracellular space between the tissue, okay, between the cells. Okay, thyroid hormone receptors, which is D, thyroid hormone receptors preferentially bind T4 and T3. No, it preferentially binds T3. The correct thing is it prefers to bind T3, not T4. So remember that 97% of hormone is T3 at the tissue level, and plasma, T4 is the majority. So 94% of the plasma hormone is T4, which is being transported. The action version of it is, the most active version is T3, which is 97% at tissue level. Okay, so T3 is the main one. It has much more higher affinity for the thyroid hormone receptor. So T3 is by far more stronger in terms of activating transcription factor or DNA translation or replication and so forth. So T3 is the main hormone in terms of target tissue. T4 is the main hormone in terms of plasma concentration. Okay, so the answer should be B. Okay, let's go to our next question. Okay, so what did you learn before we go to the next question? The following things is what you have learned. Let me write them down. Number one, thyroid hormone goes directly into the nucleus and it goes to enter the cell by passive diffusion. Passive diffusion. It does not bind to cell surface receptor. Number two, it has nuclear receptors. Nuclear receptors, not cell surface receptor. Nuclear receptor is for thyroid hormone. Cytoplasmic receptor are for steroid hormones. Cell surface receptors are for peptide hormones. Let me repeat it again. Peptide hormone, surface receptors. Cell surface receptors, peptide hormone. You can call it P for peptide, P for peripheral receptors, right? And then we have steroid hormones. Steroid hormones are cytoplasmic receptor. They have cytoplasmic receptor. Thyroid hormone have nuclear receptors. Okay, and these nuclear receptors will have three domains. They have three domains. DNA binding domain. Okay, DNA binding domain. Hormone binding domain. Domain simply means location. And transcription factor binding domain. Okay, so you should know these just because this is, I see on many exams it comes up. Okay, there you go. So those are the, so DNA binding domain, that's this area binds DNA. Binds DNA. So it can initiate transcription. Hormone binding domain, this area T3 will bind here. to the green area. Transcription factor to promote transcription, we'll bind here. Let's say put TF, that's transcription factor. This is T3. Okay, so next question is, a 35-year-old woman comes to the physician's office because of a 3-month history of heat intolerance. So again, let's look at the age, female, heat intolerance, insomnia, anxiety, weight loss, an episode of palpitations. On physical examination, she has diffusely enlarged thyroid gland. Diffusely enlarged thyroid gland. Serum studies shows T3 elevated, T4 elevated, TSH decreased. Which of the following is the most likely diagnosis? Okay, this should be straightforward for us. Okay, so this is the case of hyperthyroidism. Hyperthyroidism, very easy question. Hyperthyroidism, right? How do we know that? We know the signs and symptoms of hyperthyroid is increase in metabolism, so there should be increase in heat. So heat intolerance already here. Intolerance. So we have heat intolerance. We have insomnia, lack of sleep. Okay, anxiety. Anxiety and lack of sleep, same thing in a sense. Weight loss. You should memorize these symptoms and understand them. And palpitation. Okay, so based on symptoms, we already discussed that in the previous questions. Hyperthyroidism, basal metabolic rate will increase, so therefore you will have increase in digestion. So if you increase in digestion, GI motilities. The way I approach these questions, let's put it this way. Thyroid hormone is going to increase your CNS, right? And it's going to increase it's going to affect your heart, brain, heart, lungs. It's going to affect, let's say, GI tract. What else is left? Skin, sure. Okay, and I think that's enough. Let's say, okay, in the CNS, what is it? It's going to make you super alert. The purpose of thyroid hormone is to increase your basal metabolic rate, and by doing that, your brain it gets more glucose, more nutrition, more oxygen, becomes super alert. So CNS will be, so as a result, you will have insomnia, which is already here, insomnia, and you will have anxiety, okay, alertness, wakefulness, awakeness, all those things. In heart, it's going to increase your heart contraction, therefore it can lead to palpitation like AFib, and it will increase systolic pressure, but it will also decrease diastolic pressure. So that's one way. I'm glad I mentioned this because sometime on step 2 they give you a question with a heart blood pressure 170, systolic and diastolic becoming 60. See, diastolic went down and systolic went up. This is usually hyperthyroidism. Okay. Lungs will increase respiration, and GI motility will increase. If motility increases, that means fluid and food and things will be passing faster through the intestine, so it will have less time to reabsorb, so it can lead to loose stool such as diarrhea, and you won't be able to absorb a lot of nutrients, so you will have weight loss. So look for those things. Skin, so when your metabolism increases, obviously you're going to sweat. You want to get rid of like the heat and so forth, so your skin will be moist, warm, and then it will affect your hair become fine and thin. So look for those things because it's a global hormone. So we know it's hyperthyroidism, definitely from symptoms, right? And then on the physical exam, it's telling you diffusely, not just one area, the entire thyroid gland is enlarged. Diffusely enlarged thyroid gland. That's very important. Thyroid gland. Okay, because the cause of hyperthyroidism are what? Graves, plumbers, right? Graves, plumbers, what else? Maybe I should look over these choices too. Graves, plumbers, adenoma, pituitary adenoma. Okay, you can have pituitary adenoma, you can have thyroid adenoma. So these are some causes that I remember, and maybe you can take external, the choices are there anyways. Okay, so let's look at them. Let's look at these choices. So when you look at in hyperthyroidism, when the entire gland is enlarged diffusely, that means it is not a mass, it's not adenoma, and it is the thyroid gland is hyperstimulated, which means the thyroid gland is hyperstimulated, which can lead to Graves' disease. So this is diagnosis of Graves. And in Graves, when you look at the lab, T3 increased, T4 increased, TSH decreased. If TSH is decreased, that means the problem is not in the pituitary gland, right? Because the negative feedback is working. The problem is in the thyroid hormone itself. So this is, the diagnosis is primary hyperthyroidism. Primary hyperthyroidism. So that's your diagnosis. Let's go to these choices. Autoimmune thyroid hyperplasia. Autoimmune thyroid hyperplasia is in case, so that will be TSI, thyroid stimulating immunoglobulin, in Graves' disease, acting on the entire thyroid gland. So it stimulates the entire thyroid gland. So the whole thyroid gland will be enlarged uniformly, diffusely. Not one area is enlarged and the other area is not. Okay, so that should be the choice. So this is Graves, which is the autoimmune disease, TSI. Pituitary macroadenoma. If there was pituitary adenoma, we will have increase in TSH. In our question, we have decrease in TSH. So pituitary adenoma leads to increase in TSH. So that's secondary hyperthyroidism, right? And it will lead to increase in T3, increase in T4. But we don't have that. We have decrease in TSH. So we're not going to choose B. Okay, so pituitary macroadenoma is very easy to rule out because TSH should be high, but in our question, TSH is low. Surreptitious and external ingestion of thyroxine. So people who just take thyroxine for weight loss and stuff. If that was the case, so you will have increase in T3, increase in T4, because you're taking it from external, right? So thyroxine is T4, it's synthetic T4, but nonetheless your body can convert it to T3. So if you take a lot of thyroxine, that's T4, and then in your body and target tissue, it's converted to T3, so T3 will also increase, but then it will also have negative feedback on what? On TSH. So TSH would expect to be decreased. So this matches our condition. But then, in this case, the thyroid hormone will actually atrophy, not enlarge. Okay? Because what? If you don't have TSH, we don't have TSH, well, who's going to stimulate the thyroid gland? Okay, who's going to stimulate the thyroid gland? So imagine this is the thyroid gland, and you take external T3 and T4. External T3 and T4. T4 is going to have negative feedback on the thyroid gland, and therefore thyroid gland will not be producing more T3 and T4. Okay, so because of the negative feedback, if we take thyroxine, because of the negative feedback, we will expect the thyroid gland to atrophy, not enlarge, shrink actually in size. So we would expect thyroid atrophy. Thyroid atrophy. Which in this question we don't have atrophy, we have the opposite of atrophy. It is hypertrophy or enlargement. So therefore we're not going to choose C. Isolate thyroid adenoma. If it was thyroid adenoma will have increased TSH. What am I saying? Thyroid adenoma will have increase in T3, and it will have increase in T4, and it will have decrease in TSH. So that will also could make sense. But remember, thyroid adenoma is, remember thyroid gland is like a butterfly shaped, right? So thyroid adenoma will be just one area. So on the thyroid scan, you will just see one area that produces a lot of T3 and T4. So it wouldn't be diffusely enlarged. It would be just one area, one lobe or one small area of the thyroid gland that will be hypertrophied. But in our question, it's telling us diffusely enlarged thyroid gland. So the one thing that helped us the most in answering this question was this diffusely enlarged thyroid gland, which is unique for Graves' disease. Okay. For Plummer, it is nodular thyroid, not diffusely enlarged. It's not the whole thyroid gland that's enlarged. There's nodules here and there and there. So it's multiple nodule is Plummer, single nodule is thyroid adenoma. Okay. All right. So hopefully this was helpful. Let's go to next question. Okay, so next question, is 16-year-old girl is brought to the physician because of amenorrhea. She has never had menstrual period. So if she's never had menstrual periods, she has primary amenorrhea, okay? She's 5'11", tall. She's very tall. Breast development is Tanner stage 3. She has external genitalia. Development is normal. There is no axillary or pubic hair. Which of the following karyotype is most likely? And then they give you the karyotypes: 45X, 45XX, 45XY, and iso chromosome 46XI, XQ, and triple X, 2 X's and Y. Okay, let's do this. Okay, so what do we have? Let's diagnose our condition first. Let's diagnose our condition. So we have a person that has amenorrhea, but it's primary amenorrhea because they never had, she never had her menses before. If you had your menses before and then you don't have menses later on, that's called secondary. Primary is you never had your menses. So this is primary amenorrhea. So this patient is a 16-year-old female. Okay, so let's just put that, 16-year-old female. Okay. She has primary amenorrhea. She's tall. She's 5'11". 5'11" is tall. Okay, so she's tall. And what else? She has normal genitalia. If she's a female and they're telling you she's normal genitalia, they're telling you that she doesn't have male genitalia, she has female genitalia. So normal genitalia. Okay. She has no axillary or pubic hair, but she has breast. She has breast. Tanner stage 3. Okay, so what would explain all of this? Okay, so if she's going through, she's never had her menses. Okay, she's never had her menses. She has breast, but she has no pubic hair and so forth. Remember, pubic hair requires androgen. So this would be androgen. Androgen is needed for hair growth. Okay, so that would be androgen is for hair growth. Breast requires estrogen. Genitalia requires estrogen. Okay, primary amenorrhea. Okay, so let's see what else we can do. So to see what it will explain this, I think we can use the choices to sort of reach a conclusion. 45X is Turner syndrome. I think you guys know about Turner syndrome. 45X or X chromosome monosomy is Turner syndrome. In Turner syndrome, I expect the female to be short. Remember the typical physical characteristics of Turner syndrome. The female is short, they have wide, broad, shield-like chest with no just nipples but no breast, and webbed neck. So those are the things. So short stature and wide, webbed neck, and very short neck as well. So short, wide neck, and broad chest. Chest looks like shield. You remember those in the times of sword fighting when people have that round shield in the middle of there was a little dot. So just a flat. So they'll have flat chest with just nipples, no breast. So that's what they're telling you, no breast. Okay. So breasts are very small. In this case, the person has breasts that are Tanner stage 3, bigger than that. So keep that into consideration. So let's just say undeveloped breast. I'll just say undeveloped breast. or small breast or underdeveloped. I should say underdeveloped breast is much better option. They're developed, but they're not completely to the side. And also, Turner syndrome should have, for example, you should look for congenital defects such as bicuspid aortic valve, coarctation of aorta, horseshoe kidney. Look for those things as well. In our question, we don't have those. So so far it seems like it's not Turner because we have a 16-year-old female that's very tall, not short. It's tall, and then they have breast development in this person. Breast in Turner syndrome, we expect underdeveloped breast. Okay. Today I'm very tired, so excuse me for just not. My tone is very unique today. 46XX is normal female. 46XX is a normal female. So normal female should have amenorrhea at age 16. Look, you would expect 99% of girls to have their menses by age 16. So 99% of the female are expected to have their menses by age 16. This person doesn't have their menses. So 46XX female, I would expect them to have their menses. I'll expect them to have, if their breasts are on Tanner stage 3, their secondary sex characteristics should have been developed. So they should have pubic and axillary hair, and this person doesn't have it. And 5'11" by age 16, no, okay, it's a little bit tall. So let's keep that in mind for now. Let's say that's possible. 46XY is a male. Okay, could a male, genetically male, so this is genetically male, could a genetically male appear phenotypically as a girl? Genetically male, could genetically male have phenotypic characteristics of female, phenotypically female? Do we have something like that? Yes, we have something like that, and that's called androgen insensitivity syndrome, right? Or testicular feminization syndrome. Insensitivity syndrome. Okay, so the issue here is in androgen insensitivity syndrome, we have androgen receptor deficiency. Androgen receptor deficiency. So you do have androgens. The person will have androgens. They have androgens, or they have testosterone. So androgens are increased. You would expect their androgens to be increased, or testosterone, right? The main androgen. But they don't have receptor. So if they don't have receptor, then therefore they will not have the external genitalia. So remember, in men, the Y chromosome have a gene that is coding for testes. They will have testes. So testes will develop in these male, and the testes will produce testosterone and dihydrotestosterone. But because there is no receptor, that means the person will not be responding to testosterone, dihydrotestosterone. Even though genetically they're male, they will not develop their male characteristics. Okay. For example, dihydrotestosterone is required for external genitalia, and testosterone is needed for internal genitalia. Internal genitalia are, for example, vas deferens, seminal vesicle, and then and prostate. And external genitalia is in men would be the urethra and penis, right? Or clitoris enlargement. So if you don't have receptors, so the clitoris will stay long, and genetically every human being will become female unless they have testosterone, unless they come in contact with androgens. Okay, so if you don't have androgen receptor, then the Wolffian duct will dissolve, and the Mullerian duct will develop into female characteristics and female organs. Okay, so two things required: Mullerian inhibitory factor, remember that, and you will need to have testosterone. So anyways, these people with androgen insensitivity syndrome, they will have testes, but they will have external female genitalia. Okay, so they will have external female genitalia. and we'll be looking for that. So, and since they don't have testosterone, it makes sense that most of the testosterone then will be converted to estrogen, because there's excess of testosterone, it's not being used. So estrogen will increase, and the estrogen will cause the breast to enlarge and grow, and no testosterone receptor, so there'll be no pubic hair. This person has no pubic hair, enlargement of breast, and the female genitalia are normal. But if you take CT scan or something, they will not have the female uterus and so forth, and the vagina will be blind pouch, because they will have only the lower 2/3 of vagina development. The upper 1/3 is depending on the Mullerian duct, so which will not Mullerian duct will not develop, because testes will produce two things: Mullerian inhibitory factor and testosterone. Testosterone will promote the Wolfram duct to become male genitalia. Mullerian inhibitory duct will prevent female female internal organs from developing. So when you have Mullerian inhibitory factor produced by testes, this person will not develop uterus. So uterus negative, no uterus. They'll have no fallopian tubes. So no fallopian tubes, because the Mullerian inhibitory factor produced by who? By testes. And they will not have what else? Cervix. And they will not have the upper 1/3 of birth canal or vagina. So they will not develop those. But testes should become to enlargement of clitoris, the penis development. But because this person has no receptor, so they will have external genitalia, a female. Okay, but the vagina will be blind pouch. It wouldn't be an open, because there is no uterus and there is no cervix. As a result, they will have primary amenorrhea. Okay, they don't have uterus, so they will have no menses. Okay, and they don't have ovaries, instead they have testes. So on physical exam, you can palpate the testes probably in the scrotal area in this patient. So anyways, 46 X and then I in a bracket XQ is deletion of X chromosome. That's the same thing as Turner syndrome. That's another version of Turner syndrome. And then 47XXX triple X syndrome, that's trisomy. So this will be trisomy X. Trisomy X patients are usually very tall. Okay, they will have mental retardation, but they have normal pubic hair and axillary hair, because they have androgen receptors. So that wouldn't meet the criteria as well. And then 46XXY is Klinefelter syndrome. So Klinefelter syndrome is male with one extra chromosome X, copy of a chromosome X. They will have small testes, infertility, they'll be tall, they'll have gynecomastia, they'll have male genitalia though. This person has female genitalia, so the best option will be normal female with a phenotypically, but genetically they will be male. So let's choose C. That's the best option. Okay.